Good evening. This is Dr. Bernstein with the January 25th Teleseminar. Before we begin, I want to remind you that my answers to your questions are really guesses. I don't know your complete history. I don't know your family history. I'm making assumptions when I read your questions, assumptions about you or your health or whatever, and I'm making a guess. So you can't really go by what I say, but I may have made a good guess, and you can discuss my suggestions with your physician. We have a special subject today, which has to do with the fact that metformin can impair the absorption of vitamin B12. It doesn't do this to everybody, but it does do it to a certain percentage of the users. And I just stumbled on an article that I saw several years ago, I think in 2010, that points out that you can avoid the B12 reduction if you take calcium carbonate with the metformin. And they make a suggestion of taking just one second. I have to find the article. 1.2 grams per day of calcium carbonate if you're taking metformin. Now, a 750 milligram tablet of Tums has 300 milligrams of calcium in it. And 4 of these Tums will add up to 1.2 grams. So what I'm suggesting as a possibility is one 750 milligram Tums with every metformin tablet you take. If you're taking the glucophage XR, which is the time-release metformin, the maximum dose is 4 tablets a day. So if you were to take one Tums with each metformin, you'd get 1.2 milligrams per day, 1.2 grams per day, So that's my little bit of new news, which is really not new news, it's old news. To cite the article, it's in the Southern Medical Journal, 2010, number 103, pages 265 to 267. We're not going to be able to give you this reference again, so be sure to write it down if you're interested. Southern Medical Journal, 2010, number 103, pages 265 to 267. Now, this might be the 103 edition, number 3, but it's pages 265 to 267. Okay, now we're going to go for today's questions. Type 1 with a A1C of 6.6 for 2 years. What is the best test to see if I have any heart damage besides the stress test? The best test, I've told you before on these seminars, is a coronary artery calcium score plus a CT angiogram plus coronary artery density, calcium density. The high density calcium in the coronary arteries is less likely to break off and cause an obstruction upstream. So that's the reason for doing the density test. The calcium score shows you the total amount of calcium in the coronary arteries. And the angiogram shows if you have any blockage or near blockage in specific branches of the coronary arteries. Next question. In your conferences, you often quote A1C to glucose milligram per deciliter readings. What this person is talking about is the conversion of A1C readings to blood sugar readings. But your conversion differs significantly from those I find online. Why are your glucose averages so much higher than the reference that I've been seeing online? Well, I've explained this before. I'll do it again. A deal was made between a couple of doctors and the company that makes the lowest reading blood sugar monitor on the market. It also is the one with probably the highest variability from one finger stick to the next. These physicians were paid very highly to use this particular meter, which was given to patients who recorded their blood sugars day and night for a period of time. And the readings are essentially worthless. So the blood sugar readings that were secured were not very accurate. In fact, they were way off, and they tended to read quite low. Yet the American Diabetes Association accepted these readings for blood sugar, which were then correlated with A1C readings for various patients. So the ADA, of course, likes to show low blood sugars for their A1C readings because they've been recommending very high A1C readings. That's the story. I'm not going to give you the names of the physicians who are involved, but you can look them up if you're very careful. And I'm not going to tell you the name of the meter that was so inaccurate, but you can look that up if you're that interested. By the way, the study that we used is mentioned in my book, Diabetes Solution. It was actually published in the journal Diabetes Care, and in those days, the people who did the study got accurate results. And they matched, at least for blood sugars near 100, they matched the results that I had gotten for A1Cs when I looked at many patients. I would like your reaction to the statement in the journal Nutrition. I'm sorry, not in the journal Nutrition. In the book Nutrition for Dummies, that states carbohydrates provide nutrients for the friendly bacteria in your intestinal tract that help digest food, and they assist your body's absorption of calcium. Well, if Nutrition for Dummies is referring to vitamin D for the absorption of calcium, it's saying something reasonable. But vitamin D is not water soluble. You will not find it in carbohydrate foods. You'll find it in animal foods, in fishes, and so on. So we can't say that carbohydrate foods are going to enhance your absorption of vitamin D. As far as other comments made in Nutrition for Dummies. Maybe if you're using this book, you're a dummy, and maybe you're getting dummy results, but there are many carbohydrate vegetables, but they're low carbohydrate vegetables that have vitamins. And the reason I recommend any carbohydrates in your diet is to get vitamins from low carbohydrate vegetables. The low carbohydrate vegetables are not the starches. The starches are just giving you mostly sugar, not nutrients. So I have not read Nutrition for Dummies. I don't intend to read Nutrition for Dummies, but I see no reason to consume high carbohydrate foods either for diabetics or for non-diabetics. Would you please elaborate on the following warning you gave about taking antioxidants, including R-alpha lipoic acid and cancer? And now this person is supposedly quoting me. Cancer cells can thrive on antioxidants. If you have a family or personal history of any form of cancer, it would be wise to steer clear of R-alpha lipoic acid and other antioxidants. Well, this is not quite the whole story. And when I did discuss this in a prior teleseminar, I pointed out that cancer cells go through phases of growth. Some phases, they require antioxidants. Some phases, they're harmed by antioxidants. So it's a varying situation. And the problem is you're not going to know what phase any group of cancer cells are in, whether they can be helped or harmed by antioxidants. And my guess is that you probably would be better off staying away from them if you have any form of cancer. But if you know what phase you're in, and I don't know how you would know that, there are times when antioxidants would be helpful. Next question. I'm 49 years old, type 1 diabetic. Why my sugar does rise if I run in the morning, even if I have a good sugar when I wake up and eat a small breakfast? The opposite is true when I run in the evening. Well, this is explained in my book, Diabetes Solution. It's due to the dawn phenomenon, and it's not at all uncommon. I see this very frequently. And just yesterday, I had an argument with a lady who doesn't like to do her exercise in the evening. She finds it more convenient to exercise in the morning. And I said, well, you might have to take a shot of maybe 1 or 2 units of regular insulin to prevent the blood sugar rise that you are going to get when you exercise in the morning. And you may have to decide which you want to do. Exercise and take some insulin, or exercise later in the day and not be required to take insulin. And this I've seen ever since I was first in practice. I've told you listeners about this story before. I had a patient named Jamie who lived in Montana, out in the mountains, and he found it most convenient to run when he got up in the morning or within an hour of rising in the morning, and he took 2 units of regular insulin, and that kept his blood sugars from going up in the morning, plain and simple. Now, for more of an explanation of the dawn phenomenon, you could read my book, Diabetes Solution, but it's a real phenomenon, it's legitimate, and it does affect morning blood sugars. In your book, you talk about R-alpha lipoic acid as opposed to alpha lipoic acid. Could you explain the difference between the two? Which should you take? Well, I'm not recommending either because they are not necessary for the treatment of diabetes. For many people, they probably are a waste of money. They have been used to treat diabetic neuropathy, and how successfully is hard to tell. The alpha lipoic acid comes in 2 enantiomers, that is, 2 versions with identical chemical formula, but with different orientation, let's say geographically, or right and left orientations. And one has the right orientation, the other has the left orientation, and the right orientation seems to be more potent when it comes to treating diabetic neuropathy. And there's a product made in Florida called Insulow, INSULOW, which supposedly lowers insulin resistance, and it consists of R-alpha lipoic acid, the R enantiomer, plus biotin. Alpha lipoic acid does diminish the body's biotin stores, and if you give it with biotin, you can restore the lost biotin. That reminds me of something about biotin that you should know. Biotin can affect measurement of thyroid hormones. It can affect the measurement of free T3, it can affect the measurement of free T4, and it can affect the measurement of TSH. It all depends which company's reagents are used to do the measurements, which tests will be affected. But as a general rule, people who are having a thyroid test performed should not take biotin within the prior 3 days. You won't suffer from skipping your biotin, but you will get possibly a more accurate thyroid test. That's for free T3, free T4, or TSH. Do you have any tips on bolusing for protein and fat? Well, a protocol for the protein is given in my book, Diabetes Solution, so I suggest you read it. It's not the simplest thing in the world. I start off with a certain dose of regular insulin for 3 ounces of protein, and then I say, you do this the first time you consume some protein. You double the bolus if you're taking 6 ounces. You would triple the bolus if you're taking 9 ounces. But see what happens, because it's not guaranteed to be the same for every person. And this is stated in the book. And in the computation for protein it automatically includes a computation for the incretin effect, which is not mentioned separately, because protein tends to have a lot of bulk. And if you're taking care of the protein with a shot of insulin, you're also taking care of the incretin effect because protein has such bulk. And if you don't know what the incretin effect is, look up Chinese restaurant effect in my book, Diabetes Solution. It's the more modern term. I used the term when I wrote my first book, and that was before the term incretin effect was being used by the medical profession to describe the same phenomenon that I discovered before they discovered the incretin effect. Okay, let's see. My LDL is very high as a result of eating low carb, which necessitates high protein and fat. Should I be concerned? Well, why should you be concerned? The latest studies have shown that LDL bears no relation to heart disease, although oxidized LDL does. And oxidized LDL gets elevated when you eat a lot of carbohydrate. It also can be elevated just from elevated blood sugars. And also there is glycosylated LDL, which unfortunately is only available, can only be measured at research laboratories. You cannot buy it on the open market as you can with oxidized LDL. Oxidized LDL currently can be measured by Shiel, SHIEL laboratories, and also is available from LabCorp, because they send bloods to Shiel if you order the oxidized LDL from LabCorp. Most other laboratories, large clinical laboratories, do not measure oxidized LDL. Now, oxidized LDL can be elevated if you have a low free T3. What things can predict, what measures in the blood can predict coronary artery disease? Well, nothing can predict it as well as the coronary artery calcium score and the other tests that I recommended be done with the calcium score. You can look at your free T3, you look at inflammatory markers, C-reactive protein, homocysteine, but again, nothing really compares to getting the imaging studies that I mentioned. Next question. Can the comment on the new ultra-long-lasting next generation, the person is saying, can he comment? He's asking if I can comment on the two ultra-long-acting next-generation insulins. The first product, called Deglutic, is an ultra-long-acting basal insulin. By the way, the brand name is TeraSeba, and I'm using it for a number of my new patients. Second product, called Deglutic Plus, is a fixed-dose combination of basal and mealtime insulin, 70% Deglutic and 30% Novolog. Well, I could comment. First of all, I would not mix a rapid-acting insulin with a long-acting insulin, except for very special situations. And this is the special situation is described in my book, where we add a little bit of NPH to regular insulin before a meal for people with gastroparesis to slow down the regular insulin. In fact, we may first be giving the regular insulin after the meal to someone with gastroparesis, and then slowing it down even more by adding a tiny amount of NPH. And maybe even not a tiny amount, but that's a separate story altogether. That has to do with gastroparesis. I don't recommend mixing any rapid-acting insulin with deglutic or TeraSeba. TeraSeba, we've been having some success with for treating the dawn phenomenon. You may recall that long-acting insulins like Levemir do not seem to be working in the early morning when the dawn phenomenon is occurring. So people taking Levemir or Lantus, which I don't recommend, may wake up with elevated blood sugars due to the dawn phenomenon. And if you increase the dose, you might get hypoglycemia during the night. So we have a real problem. I take Levemir currently, and I find that my blood sugars are elevated when I wake up in the morning. We're taking a break, Dave, for blood sugar. And I can't wait overnight for my morning shot of Levemir. I have to get up at around 5 o'clock in the morning and take my morning shot then, and then I go back to sleep. Now, the TeraSeba is booked as a 2-day insulin, but it really, as with many manufacturers' claims, it really doesn't last 2 days. Most of these manufacturers do their clinical trials at much higher doses than are really needed for basal insulin, so they make it artificially last longer than it really would if you took a basal dose. So what I find is that the TeraSeba lasts overnight. You can use it to treat the dawn phenomenon in the morning for many patients. Now, I haven't treated a lot of patients with it yet. I've treated about, let's say, 6 new patients, and some of them were older patients who did not want to get up early to take insulin for the dawn phenomenon, and it seems to be doing the job. So here we're having this insulin, they claim 2 days action. We find that it manages to work overnight. You have to take it twice a day, morning and bedtime, and because it's a relatively new insulin, maybe between overseas and clinical trials in the USA, it may have been used for a total of 5 years. They haven't had major adverse reactions, but that's not long enough to find cancers and things like that. So we may or may not run into the problems with TeraSeba that they ran into with Lantus. And that's the current status. I am taking this minor risk of using it on my patients because they don't want to get up at 5 o'clock in the morning, and I don't blame them. Let's see what else we have. In your books, you say to avoid onions and garlic because of their sugar and to have shallots instead. Since onions and garlic are good sources of sulfur, what are your thoughts on the importance of sulfur in our diets, and do shallots contain it? Well, I really can't answer this question because I don't know the answers. I did not say to avoid onions and garlic. This is a misquote. I may have said to keep doses of onions relatively small, like having one slice instead of a stack, because they have more carbohydrate than other vegetables. And I said nothing about garlic. I may have mentioned once that I have trouble digesting garlic and onions, but that's a problem of my family, and I'm not telling other people to avoid them because of my problems. Uh, and what about the body's need for sulfur? We do require sulfur, but how much? I don't know. I know, by the way, that insulin is a peptide hormone with what's called the disulfide bond. So to make insulin, you need sulfur, but you don't need to load yourself with sulfur, and you don't need to be uncomfortable by eating large amounts of foods that contain sulfur. How does diaphragmatic hernia affect diabetes? My gastroenterologist told me I have a small diaphragmatic hernia. Well, a diaphragmatic hernia is an enlarged hole in the diaphragm. The diaphragm is a membrane that goes across the middle of the body, above the stomach, and the esophagus goes through a hole in the diaphragm, but the hole may be a little too big, and a piece of the stomach may come up through that hole and be squeezed by the diaphragm so that food in that little corner of the stomach doesn't get digested or doesn't empty readily. So if it's a small diaphragmatic hernia, it doesn't cause major problems. If it's a big piece of the stomach that's caught, it can severely impair digestion. It can cause GERD, gastroesophageal reflux. A severe diaphragmatic hernia can be confused with gastroparesis, and if it's very severe, it might require surgery, which is relatively minor. It doesn't have direct effect on diabetes, but a large diaphragmatic hernia can affect digestion, and a small diaphragmatic hernia can have small effect on digestion. How reliable and accurate is the A1C in measuring average blood sugar control? When I do a fructosamine test, it seems to indicate much higher results than the A1C, and my daily blood sugars indicate. What should I follow? Well, to me, the fructosamine test has only one application that I could think of. It's good for following pregnant diabetics, especially type 1 diabetics, because it gives a 2-week, more or less, running average of blood sugar. The trouble is that I've not seen any published figure as to what blood sugars correspond to what fructosamine level. So it is tracking the direction of your blood sugars. You could see if they're going up or going down. But if you're a doctor treating a pregnant diabetic, you should be having her record her blood sugar data. So the fructosamine would really be a double check to see if the patient is not telling you the truth, or if the patient refuses or is unable to check blood sugars. It's not a measure that should be used week by week for type 1 diabetics who are not pregnant. There is no number that you could look up for what blood sugar the fructosamine corresponds to. Go by the numbers that you get on your meter, assuming you're using an accurate meter. The only time your blood sugar meter should show a discrepancy from the hemoglobin A1C would be if you're not getting blood sugars during the middle of the night. Your blood sugars at night might be different than they are during the day, and that, of course, could affect the A1C reading. But going after fructosamine if you're not pregnant, to me, doesn't make any sense. I've had type 1 for 12 years, and I've tried following the diet a few times now and had success. However, after a week and a half, my mood takes a dive. I get very irritable, depressed, and can't continue to follow the low-carb diet. Upon eating carbs again, I almost immediately feel better again. Is this an adjustment phase I have to suffer through first, or could there be some undetermined cause? Well, again, in my book, it points out that if you're used to an elevated blood sugar and you rapidly bring it down, there's a very good chance that you'll get symptoms of hypoglycemia. So that seems like the most likely thing in this particular situation. Now, there are unusual situations that I've encountered that are very strange that might relate to this, but they're rare. For example, I have one person who has strange symptoms from all kinds of foods. Different foods affect him in different ways. He also has chronic depression that is not or was not being adequately treated. And when he ate a lot of carbohydrate, his depression got better. Now, eating carbohydrate increases levels of tryptophan and serotonin in the brain and can act like an antidepressant. Prozac increases serotonin levels in the brain. So it could be that he was using carbohydrate as an antidepressant and that it was working. But this is rarely the case. This is a very unusual situation. Much more common is the feelings of hypoglycemia, which this patient describes in the question, probably due to rapidly achieving near normal blood sugar or even lower blood sugars than before. For example, I've seen people with average blood sugars of 300 get hypoglycemic symptoms when their average comes down to 200. So you have to lower them more slowly. Artificial sweeteners, in the light of research, is indicating that they may be harmful to diabetics by changing the gut flora. Your comments? Well, I've not read any such thing. In fact, there are many internet comments about artificial sweeteners that literally lie about them, make up all kinds of fantasies, and even some of these sites try to sell you substitute sweeteners that they consider less harmful, including ads for Domino cane sugar, which the ADA advocates as a sweetener. So I know of no evidence that artificial sweeteners are harmful to gut bacteria. I imagine that high levels of sugar or grains, which are alien to our early environment, that is our ancestors' environment, could be harmful to the endogenous bacteria in our gut, the microbiome, but we just don't have much information. The microbiome is really right now a big mystery, and any individuals who make claims about what they know about the microbiome are probably fabricating stories. Why do I get different readings of 103 on my right hand and 130 on my left hand? Well, first of all, it depends what meter you use. If you use the meter that I was talking about earlier, that was used to determine the current ADA, hemoglobin A1C recommendations, that meter can give you 80 in one hand and 150 in the other hand immediately thereafter. That's how inaccurate I found it to be, and variable. So it really depends on the meter. You should use the meter that we're currently recommending, and as pointed out in other teleseminars, there is now one other meter that seems to be as good in the vicinity of blood sugars around 100. That's my guess. I don't have more information. I don't know how many studies you did. I don't know how consistent your meter is if you use the same hand. But I've never seen this kind of difference with an accurate meter. When I was first diagnosed at the age of 15 as a type 1, I was at the ER with extreme dehydration, retching, double vision, glucose of 1200, but they also performed a spinal tap on me. I was wondering why they did this spinal puncture. Well, it could be that your symptoms resembled those of meningitis, and they were trying to rule out meningitis by looking for bacteria in your spinal fluid. That's one guess. Another reason is that it's very profit effective. They could charge a large sum, a lot more for a spinal puncture than for a blood sugar. So that may have been a reason. Or it could have been a mistake. Or it could have been that you were in the hands of a young doctor who just got out of medical school and didn't begin his internship or his residency yet. And it's July and the staff is changing and the guy didn't know what he was doing. So there are lots of possibilities. My 3-year-old was recently diagnosed. He is getting 2 units of Lantus at 9 p.m., but is waking up very low in the 60s, in the 40s by 8 a.m., but is running high after zero-carb meals. How do I approach this? Going low-carb has kept him out of the 200s, but he is still occasionally getting up to the 170s. I would urge you to read my book, Diabetes Solution. You might also go to the Type 1 Grit Facebook site. You could also get them on YouTube, I believe. If you're giving NPH insulin, you may be giving too high a dose, causing him to go low, and then NPH is only an intermediate acting insulin. It doesn't last very long. Maybe it lasts 6 or 8 hours. So for small kids, and you could read this in my book, we may give diluted NPH insulin 4 to 6 times a day because it doesn't last, but diluting it enables you to lower the dose. So if you diluted it 3 to 1, each 2-unit measurement would only be a quarter of 2 units or a half a unit. So you go to a compounding chemist, get the insulin diluted, and but NPH must be given anywhere from 3 to 4 times a day to 6 times a day. Read the book. Why can I get different hypo responses at the same readings of 35? Sometimes I'm sweating and stumbling, and other times perfectly fine. And I know it is not the meter or strips. This question stole a special subject that I was going to film today for my Dr. Bernstein's Diabetes University videos. It has to do with the blood-brain barrier. I remember when I got my first blood sugar meter, and I frequently observed blood sugars of 0 and asked myself, why am I not dead? Clearly, my brain blood sugar was not 0, even though my body blood sugar was 0. Well, this has to do with the blood-brain barrier. Glucose will slowly migrate into the brain if you inject some IV glucose into the body. Or if you diminish the blood sugar in the body, like bring it down to 0, glucose will slowly be metabolized in the brain, but it's not getting any new glucose from the body. Or some of the glucose that's in the brain may leak out into the body and slowly bring down the brain blood sugar. So if you've had a rapid drop in your body's blood sugar, because the blood-brain barrier slows down transit between the body and the brain, it takes a while for the brain blood sugar to catch up with the body. So you go down to 0 in your body, it happened very rapidly. The brain's going to take maybe minutes, maybe hours before it catches up and goes down to 0. But what if your blood sugar drops in the body slowly? If it drops very slowly, the blood-brain barrier keeps the brain only a little behind the rest of the body because the body's dropping slowly. Therefore, you can have changes in the brain paralleling those in the body. So when the body eventually goes down to a blood sugar of 50, the blood sugar in the brain may be 53. And your cognition is going to be impaired. You may feel sleepy. You may feel anxious. You may be stumbling. You may have blurred vision, etc., etc. So that explains the difference. And one message, of course, is if your blood sugar is low, even if you feel great, that's if you're feeling great is the most dangerous time because you think you're okay, but it's only because the brain hasn't come down yet. Okay, let's see what else we have. On page 307 of your diabetes solution book, it states, if I were to use Novolog or Opidra in place of regular insulin, I should use half the dosage. Is this a typo, as on page 290 and again on 303, you indicate the dosage should be two-thirds that of regular? Well, you have to read the book carefully. I'm not going to go back and read it. I don't have the guts to go through that again. I read it so many times when I was writing it. But this is what I probably said. I probably said you initially do an experimental dosing where if you're using Novolog or Opidra, assume that they're much more powerful than regular and cut the dose in half. And then eventually, when you end up at the final dose of Novolog or Opidra that you're going to be using, it'll probably end up more like two-thirds the dose of regular. So that would explain the difference, and that certainly explains what I explain to my patients when I train them. You talk about the benefits of bodybuilding exercise. There are reports of studies that have shown this kind of exercise, along with creatine supplementation, can significantly reduce A1C when compared to exercise alone. Is this your opinion also? I've never tried it. I've had occasional patients who did try it, and they didn't see a difference. What I read in the few reports that are out there is that the effect on blood sugar of the exercise, or on insulin resistance of the exercise, I should say, is increased when you take supplemental creatine. Now, that may or may not be true. From what I've read, it seems that the creatine is advocated mostly for bodybuilders and people who exercise very strenuously, and may help reduce body fat and increase body muscle. It may be true, but I've not seen direct evidence of this. Can you review the risks of using vanadyl sulfate? Well, I can only think of two. Just let me... in my experience, vanadyl sulfate is one of the few supplements, in fact, the only one I've seen, to have a potent effect on blood sugar. That is, a blood sugar lowering effect that was measurable, where my patients saw a significant difference. And the major effect I saw was in one patient who had a cookie store on the ground floor of her apartment building, and she would stop off there and eat cookies, and her blood sugar would go sky high. And if she took vanadyl sulfate, it didn't go as high. In fact, her A1Cs were the best I had seen in her with the vanadyl sulfate. Now, there are two problems. Vanadyl sulfate is packaged differently by different suppliers. And even from the same supplier, you have no evidence that you're getting the same amount in every capsule or in every bottle. So there's no guaranteed consistency of it, either in concentration or in the total amount they put in. That's one hazard. Since it can lower blood sugar, you can get hypoglycemia, especially if you're taking insulin at the same time. So there's the uncertainty. But more important, I think, is the fact that it is a phosphatase inhibitor. It inhibits an enzyme that breaks the bond between phosphate groups and other molecules throughout the body. Now, since phosphatase is important in chemical reactions everywhere in the body, maybe hundreds of thousands of chemical reactions that we don't even know about. By inhibiting phosphatase, we don't know what we're interfering with. We don't know what potential damage we could be doing. And since this is well known, one of the few significant quantitative studies of vanadyl sulfate, which was done at my medical school, was terminated deliberately after 3 weeks because they didn't know the long-term effects. And that's a risk that someone would be taking. And I don't want to take the risk with my patients, so I've not been advocating it for my patients. But also, I like predictability, so that's another reason for not using it. A 27-year-old male with type 1 diabetes tried your diet for 1 week, sugars improved, but had no energy and was this is he works out 4 times a week, including boxing. Is there something I can do to get more energy? Would eating 20 carbs every meal push the boundaries of the diet too far? If this is a type 1 diabetic, the 20 grams of carb would certainly be pushing the boundaries, would force you to take more insulin. I think that you really should be could you be using an inaccurate meter? Sugars improved, but no energy. When someone says sugars improved, I'm wondering whether they're really using my book, because what I expect to see is sugars are essentially in the normal range 24 hours a day. And sugars improved could be that they came down from around 300 to around 200. And we really should be striving for normal blood sugars. That comes first. And it could well be that you're getting highly variable blood sugars and you're going too low. And you have to use an accurate meter. And you should get to the meter that we've been recommending, which, again, right now is the Freedom Freestyle and the Freedom Freestyle Lite. My doctor has told me that because of the results of my C-peptide, that I will always be on insulin. Can a type 2 reverse the beta cell burnout? Well, that's a good question. A type 2 can reverse the beta cell, can partially reverse the diabetic if caught very early. We've done that with type 2s that were caught early, where we gave them insulin and after a while didn't need it. there's much literature to the effect, normalize the blood sugars up front early, you may get a partial reversal. Once you've had significantly elevated blood sugars for an extended period of time, the best you could do is your very best to keep them normal, not to search for a cure, but to prevent more beta cell burnout by keeping blood sugars normal. Well, that's it for today. Our next teleseminar will be January 27th on Wednesday. I invite you to join us. Thanks for listening. We'll be glad to be talking to you again. Oh, wait, I made a mistake. It's February 27th. We'll talk to you. Our next teleseminar will be on February 27th. Please join us then. Thank you.